Hello everyone. October is observed as the Breast Cancer Awareness Month. So are we aware? Let's find it out. How huge is the burden? It's reported that in every 4 minutes, one woman is diagnosed with CA breast. So the number is pretty big. It's obvious. So what can we do about it? We have to catch them young. That is, try to detect the malignancy, possible malignancy at an early stage so that you can intervene in given time, in an adequate time, and bring a positive outcome in the woman's life. So for that, what do? We have to go for screening. Basically, what do you mean by screening? Screening means in any person who is totally asymptomatic, that is, has no complaints, no lump, no discharge from nipple, no pain, nothing at all. But you still have high suspicion, or you suspect because the person is having a risk. What is the risk? She is a woman. She has got breasts and she's likely to develop cancer. So, in such a scenario, you're trying to intervene in some way possible so that you can pick up an abnormal lesion at a very, very early stage. That is screening. So we're aware of the self breast examination technique, which we ask the women to practice so that they can detect it in their routine day-to-day life. Or else we've got the clinical breast examination where clinicians perform breast examination in persons with risk factor. Definitely all the women are having risk factor, but we know that as in any case of malignancy, CA breast too affects the older people, older generation, the elderly generation. So beyond 40 to 50 years, you can have a routine breast examination by a clinician, by an experienced person. Then also you can detect early lesions. But the problem is that by the time you detect a lesion, when it is actually palpable, or by the time you can feel it, it still may be late. It may not give the advantages that it intends to. So we should have some other imaging modality by which you can detect the lesion at a very, very early stage, at the root stage itself, before even your hands can feel. Hence comes the roles of radiology, imaging in CA breast detection, screening, diagnosis, and possible treatment. So what are the imaging modalities that we are aware of? You've got the X-rays, yes. You've got the ultrasound, and finally you have got the MRI. So the clinician is confused. He's posed with lots and lots of options. So which one will he choose? So the answer has been made very simple. By whom? The various societies, various conferences, discussions, and we have got the Society of ACR. We have got several other societies in the name of Society of Breast Imaging, then the American Cancer Society, and the like. So they have all done what? They put guidelines. Okay, guidelines in regard to what? Guidelines in regard to age at which you have to perform screening. Okay, so the age, remember the golden number 40. Why? As per ACR, you can begin CA breast screening by the age of 40 years on an annual basis. So the question naturally comes, how long? Answer is that till 5 to 7 years of life expectancy that is left for the patient, either taking into consideration her age or taking into consideration her comorbid status. So then the guideline also specifies the modality, imaging modality of choice. And the answer is among mammography, among ultrasound, and among MRI, the answer is definitely mammogram. Why? I'll tell you why mammogram is taken as the imaging modality of choice for screening of CA breast. There are mainly 3 reasons, and there are many more, but I like to highlight 3 important reasons. Reason number 1, we are taking CA breast, taking into consideration not just the age of the patient, but also the breast composition. So when the patient is young, what happens? The breast will have predominantly the glandular tissue interspersed with fatty tissue. So we all know that breast is a dynamic tissue. It keeps on changing. Lots of hormonal influence and it undergoes lots and lots of change. As a result of which, once a woman ages, like as she becomes older, the entire glandular tissue may undergo atrophy and may undergo fatty replacement. There lies a significance. What is it? In a fatty replaced or fatty breast parenchyma, lesions can be picked up easily in mammogram. So mammogram brings out the contrast. Most of the lesions appear on mammogram, which is basically X-ray, as dense structures. So fat is appearing lucid or dark, so the contrast is brought and you can detect the lesion very easily. That's reason number one. But there is a reason number two. What is it? Ultrasound is actually an operator dependent procedure. But whereas in X-ray, we're getting the machines to take the image. You're compressing the entire breast parenchyma and the machine is obtaining image. You just have to read it. But in ultrasound, you have to perform and you have to analyze. So in cases of in cases of large breasts, it will be like you're searching amongst the ocean, deep into the ocean, diving deep and searching, and there is high chance that you may miss. But whereas if the patient has got a lump, you can palpate, you can feel it, then you can go for ultrasound straight away because you're doing a targeted exam. So when you're considering screening versus diagnostic or screening versus targeted exam, you go for ultrasound more for targeted exam for the reasons already mentioned. Now reason number three. I said in screening, our aim is to detect early lesions. So what is the morphology of early lesion? It can present as a mass, yes, but more importantly, it can present as microcalcification. These tiny white dots that you can see in this X-ray, in this mammogram, these are nothing but microcalcification, excellently seen by mammogram. But what about ultrasound? It is difficult. You can pick it up, but if isolated, it may tend to be really, really, really difficult. So considering all these factors and several other features too, by the consensus, screening, we are using mammogram. So remember, gone are the days when we used to manually develop X-rays. So similarly in mammogram too, which is basically an X-ray, lots and lots of evolutions have come. And the one important is that we have moved from screen film to digital X-rays. That is, you take the image and immediately you get it on computer. You don't have to take out the film and put it in an image receptor like that. Nothing of that sort. Directly you can get. Similarly, much more evolutions have come and we are now dealing with digital breast tomosynthesis. So in screening protocol, by mammogram, the preferred one is digital breast tomosynthesis. Why? What are we actually dealing with in digital breast tomosynthesis? As the name suggests, we're getting slices. See, you have a patient here with the breast parenchyma kept compressed. And instead of the X-ray tube being static, it is going to move in the form of an arc from one way to the other. And while doing so, what is doing? It is clicking multiple slices of the breast. You're getting multiple cuts. And what can you do finally? You can compile the cuts together and you can image it as a stack by scrolling, just as in CT. So it is like a 3D reconstruction. Okay, 3D reconstruction. We are getting volume of the breast parenchyma in thin slices. But it is not a 3D image, but you are getting a 3D effect. So I'll tell you an example. Suppose you are going to image this bowl with lots of colored pebbles. Suppose you're going to obtain a static 2D image as in a simple X-ray, simple mammogram. What are you going to see? You're going to compress it and you're going to get a single image, 2D image, and it will be something like a mixture of these colors. It is not going to be that useful. But if I were to go for digital breast tomosynthesis and imagine that in the pebbles within the bowl are arranged in layers and one layer representing one color or something of that sort, what you can get by DBT is that you can get slices, one slice, next slice of similar color pebbles, next slice, something like that. So it will provide more of meaningful information. That is, instead of viewing the entire compressed breast parenchyma as a single image, you're going to split it into multiple. So you're going to remove the overlapping artifacts. You're not gonna see lots of artifacts. You're not gonna have lots of dots. That's the advantage of digital breast tomosynthesis. Now somebody asks you, so has MRI got no role at all? I've heard so. The answer is that yes, MRI has got a role in screening, but not in all cases. Then which all cases? Here I like to take you to one famous personality. We all know that this is Angelina Jolie, and few years back she had made a lot of headlines because she had undergone bilateral prophylactic mastectomy. Why? To prevent the remote chance of developing CA breast. So they may be wondering, why has she undergone? Everybody has got two breasts. No, she had a particular mutation in a gene called BRCA1. And as per studies, if somebody has mutation in this particular gene, he or she is likely to develop breast cancer to the order of 85 to 87%. The risk is huge. So she was not ready to take the risk. So she underwent mastectomy. But why have I brought this case here? Because this is one of the indications where you will go for MRI too for screening. And remember, MRI is not used alone, but along with, in adjunct to mammogram, you can use MRI for screening when you're getting suspected cases of family members showing BRCA1 positivity, or the person in question itself is BRCA positive, BRCA1 or 2. And then if the person in question has undergone previous chest radiation, we know that radiation poses a risk to develop cancer anywhere in the body, cancer in the region of all the regions included within the radiation port, anywhere. Okay, so those people who have undergone chest radiation too are at a higher risk. They are not average risk, they are at higher risk. Then if you have a family member, a close relative having CA breast, again they have become high risk people. So all these are high risk candidates. They can undergo MRI screening too. So for these high risk people, we are offering them a combination of MRI along with mammogram, either concurrently or within a gap of 6 months. So it is not a replacement but an adjunct. So why not USG? Has USG got no role? Yes, USG too can be used in screening along with mammogram in cases where the person in question has got dense breast. So I've given you two images. So in which one of them? It is for this one. In this one, you're going to opt for an added imaging modality along with mammogram. Why? Because this patient has got dense breast parenchyma, whereas in this person, there is more of fatty tissue. Now let's take mammogram for comparison. If I were to obtain mammogram for the patient or person number 1, I'm going to get a fatty breast, right? So the X-ray is like this, and we know that the breast CAs can be detected in mammogram as dense structure. So any lesion here will be picked up very, very, very easily. But what about in case of those with dense breast? The parenchyma is already dense, so a malignancy, can it be appreciated among this lots of chaos? No, definitely it's going to be very, very difficult. So you have to opt for added modality for screening in the form of ultrasound. Now I'll show you few prototype examples, prototypical things of CA breast. You get a mammogram picture like this, you can be always sure that this is a case of CA breast. You have got a speculated lesion and you can spot tiny microcap. Now coming to ultrasound, how does the image look like? You've got a dense hypoechoic lesion, a large hypoechoic lesion which is taller than wider, and there is lots and lots of shadow. Typical for a highly malignant lesion. So you come across these lesions, stamp it in your mind that this is not going to be good for the patient. Now, how do you confirm? Imaging provides a clue, but for definitive diagnosis, you need pathology. So are we going to cut off one of the patient? No. You don't have to. For screening, you don't have to. Why? First of all, you're not going to detect any lump, okay? Like lump which is palpable. It's all detected by imaging. So we're going to try to get the specimen by imaging modality too. So what are our options? We can have FNAZ, or we can have core needle biopsy, or we can have vacuum associated biopsy. Okay? And suppose you are detecting a lesion in ultrasound. You want to sample it. What do you go for? You can go for FNA straight away, or you can go for core needle biopsy, preferably core needle biopsy. And supposing you're not able to detect any lesion in USG, then what is our next option? We have to go for higher imaging modalities like MRI. And in MRI, you're detecting focal enhancement or suspicious of a lesion. What would you go? You can go for biopsy under mammogram too. And there you can prefer vacuum associated biopsy. Or if you're seeing a lesion or tiny microcal or focal asymmetry within mammogram alone, non-detectable under USG, again you can go for biopsy through mammogram. That is not a stereotactic biopsy, and you can use vacuum associated technique too here. Yeah, the basic thing in vacuum associated biopsy is that in the other cases we are using manual pressure or capillary action to get the specimen. Here we are connecting a device to a specified needle or special needle, applying vacuum, which is trying to collect lots of specimen. So that is the only difference and the imaging modality that we're using. And you can have the patient position in a prone on the table, lying down on the table like this, or patient sitting, and you can perform stereotactic biopsy under mammogram, or you can go for even MR mammogram associated biopsy. So with this, what have you seen? We have picked up a subtle suspicious lesion. You're going for biopsy. Once you're getting the pathology that it is positive, now you've done your job. Now you have to go and offer the patient the best possible treatment. So remember, time is life. There is loss of life if the time management is lost. And this is of absolute significance in case of CA breast. So friends, be aware, create awareness, and try to save as many beautiful lives as is possible. Thank you.